We'll make a start now. Hello, everyone, and welcome to the Pearls Lecture Series of 2023. My name is Bilal. I'm a third-year medical student at the University of Melbourne here in Australia. And before we get started, I'd like to before we get started and I introduce our speaker today, I want to quickly talk about Pearls as an organization. So Pearls stands for POCUS, for Emergency and Acute Care in Resource-Limited Settings. Last year in August, the inaugural Pearls course was run in Port Vila in Vanuatu, where Vanuatu doctors received handheld ultrasound probes to plug into their smartphones as well as tablets. And they undertook a 3-day course of ultrasound training from a visiting team of Australian physicians, as well as other experts as well, and Dr. John O'Henry, who was the lead of the Pearls program. So after the course was completed, these upskilled physicians had the opportunity to receive feedback via remote imaging softwares, and since then, the Pearls lecture series was also put in play so that Pearls as an organization can continue supporting our doctors from these resource-limited settings in their emergency as well as their acute healthcare provisions. So today we're going to be kickstarting our lecture series, our very second lecture of our series, with our second lecture being the FASH ultrasound in HIV and TB co-infection. So this lecture will be given to us by Dr. Gabin Mbanjumucyo, and a little bit about Dr. Mbanjumucyo. So he's an emergency medicine physician from Rwanda who's currently practicing in one of the UK's busiest A&Es. In addition, he holds a fellowship in point-of-care ultrasound. His ultrasound skills were mostly based in low-resource settings where there is very minimal radiology expertise and as well as infrastructure. And besides ultrasound, this is where bedside ultrasound is actually used to make life-saving decisions as well as interventions. So Dr. Mbanjumucyo he's also conducted research in the past as well on ultrasound specifically in the applications of ultrasound and diagnosis of tropical diseases, which is really fitting for our talk today. So we're very excited. So Dr. Mbanjumucyo, welcome. Before we get started with your lecture, I was hoping that you could perhaps quickly shed some light on your journey within ultrasound and how you make ultrasound, put ultrasound into practice with your current emergency medical practice as well.
Thank you, Bilal. My first journey with ultrasound started about quite 10 years ago, probably when I was just about to graduate as a medical student. There was this American project that came to Rwanda. I did my medical degree in Rwanda, and they were bringing the concept of ultrasound. That time, Rwanda had got a lot of donations in terms of ultrasound, and ultrasound was mostly used for gynecology, mostly obstetric, rather than anything else. So we started using ultrasound as point of care, as we didn't have, at that time, there was only about 7 radiologists in the whole country. So to ask specific questions, especially cardiac, things like cardiac, there was a lot of rheumatic heart diseases. There was quite a lot of trauma. It was a developing country. As you're developing, there's a lot of building, there's a lot of injuries. So kind of answering yes or no answer. And then we kind of did a lot of studies around that, and it seems like ultrasound was changing a lot of patient pathway in terms of outcome. And also do remember that things like imaging, like CT scans, X-rays, despite them not being available, but they were a little bit costly. While with ultrasounds, while they were donated machines, they were quite free access. We are not charging them to get imaging on these patients. So with that, ultrasound became very popular. We ended up doing a lot of studies, and we got sponsorship to do fellowships. And while here in the UK, I also do quite a lot of teaching. In the UK, when I started, I've been here for 5 years now. And in the UK, ultrasound was not popular up to 2 years ago, but now it's really, especially at hospital I work in a major trauma center. Ultrasound is part of assessment of trauma, assessment of almost everything now. So even in the UK, it's really becoming popular. I'm very sure in the US, it's quite a popular thing to do. So there's quite a lot you can do with ultrasound, but unfortunately, there's really not standardized ways of accepted ways of protocols that ultrasound has to be, done in a particular way, and part of assessment, where you have the radiological societies
Mhm.
saying about, see, do ultrasound and do CT scans. So it's something is still in development, if that makes sense.
Right, of course, yeah. Well, thank you so very much for that insight. I think it's really helpful for us, especially with our viewers being all across the world, from the States, Canada, Pacific Islands, as well as many parts of Africa as well. I think your insight there is quite on the dot, talking about how point-of-care ultrasound is quite literally changing the game in medicine completely, specifically in the UK as well, where it wasn't a thing 5 years ago, but lately we're seeing more of it come into clinical practice. So that's some great insight. Thank you so very much. So we'll make a start now. And just before that, if I could please ask everyone to keep their microphones on mute and save some questions towards the end, or just chuck them in our chat and we can discuss them after our lecture. All right, so Dr. Mbanjumucyo, we're super looking forward to your lecture today. So please, whenever you're ready, you can make a start.
Sure. Thank you. So this is a plan we're going to follow. We're just going to be literally, and I can discuss, there's no conflict of interest in this lecture. Just starting with tuberculosis, I got data while looking at this 2016. There might be new data, but the data I got was the accurate ones were in 2016. And there were 10 million new cases of TB, and most of them were in Africa, and in developing countries. And most of this HIV, in terms of, we are going to talk about FASH, so it's about relationship between HIV and TB. 78% of these co-infections were mostly in sub-Saharan Africa, and there was quite a lot of deaths, 1.7 million deaths, due to different things. It can be because of severity, because of inaccess, and also because of late diagnosis, and that's where ultrasound comes in. We do see that extrapulmonary TB tend to be more as there's immunodeficiency. As a patient gets sick, low CD4 count, they tend to be prone to extrapulmonary TB. Just on the basics of diagnosis of TB, if you are able to culture a Mycobacterium tuberculosis as the organism, then you'll be able to get your TB. That's the only way to confirm that you have TB. Now there are bedside kind of tests, which are the gene experts probably should be able to get the results within a few hours, depending on how your resources are available. But as you understand, some places might be struggling a little bit more than others. And saying that as well, developing countries and developed countries don't have the same burden of tuberculosis, as so that the resources being put might be a little bit different. Also, the guidelines on how to get treatment, to start treatment, and how to how to come up with a diagnosis might be different. So talking about maybe from a global health perspective, there's that's why it's very interesting. We tend to, developing countries tend to adapt guidelines from high-income countries, and actually the epidemiology, the resources, the manpower in terms of resources in money, in terms of equipment and manpower are not totally different. They are not the same. And also the population and they are not different in terms of culture, understanding, and expectations. So if you're working in a developing country, it's really good to look at developed countries on how their guidelines, because they might have done this. But when you're about to implement them, you have to be a little bit careful. We tend to get, if you're a developing country, you tend to be overshadowed by just adopting developed countries' guidelines, but that should be thought of before you do that. So by getting all this, getting the samples might be a little bit challenging, because the samples, let's say pulmonary TB, we are talking about extrapulmonary TB. The samples might have be a pleural effusion, might be ascites, but they might not be enough bacillus to culture them, and you might get false results. And taking into consideration that the cultures do take about anything between 2 to 8 weeks for the cultures to grow so that they can be run. So despite you waiting for a long time, and not just the time, but you are also not having enough bacillus. So you might actually not get the results, and you might be giving treatment, which is, of course, someone might have the symptoms of an infection. You might giving treatment and giving antibiotics for long, they come with its own side effects. So those are the areas that you can get TB. It can be anywhere from the brain, anywhere from the reproductive organs, abdomen, spleen, bones, spine, and everything else. We're not going to talk about scanning the spine, scanning the brain. I know I haven't found studies of people scanning the brain, but there's something you might consider if you are an ultrasound, if you like ultrasound, something you might can go into. So the pathological fluids that you're trying to see. So when you're scanning ultrasound, mostly ultrasound tend to scan, you're looking for anything that's hypoechoic, hyperechoic. In other words, fluid is really good with ultrasound. So anything that in a pocket that you collect fluid, that's where you are trying to find. That's where ultrasound comes in. That's a periffusion, pericardial effusions. You can get peritoneal fluids. Of course, you're not going to go through bones unless there is a break through a bone. There's an abscess, a lesion through a bone. You might be able to pick up that lesion, but otherwise, we're not going to go through the lungs unless there's periffusion, because ultrasound will not go through the air. Abdominal lymphadenopathy, that's aortic nodes. It's really one of the things that you are trying to get, and quite also sensitive. Hypoechoic lesions in the spleen and liver. These are things also you're trying to look for. Having spoken about that, let's go back to the basics of ultrasound. An ultrasound is mostly used as a point of care test. It's a yes/no answer. If you're going to do a point of care, a urine test on a patient, you're looking for a few things. It can be, is it nitrites? Are they positives or blood in urine? That's a yes or no answer that you're trying to get, but it doesn't really tell you that fine, this is the bacteria that we are getting from the urine test. So, or this is how much they are sick, or this is how much blood there is. It's a yes or no answer. So any point of care answer is trying to give you a quick way of orienting you on a patient pathway or diagnosis, giving you some clues on diagnosis. It's not going to give you exactly that, it's not going to give you the exact answer of what the patient has. It has to come in with your clinical examination. It has to come in with your instincts, and diagnosis, examination, also counseling. Another sound on that basis is an addition to your clinical examination, to your history, and other exams you're doing. So ultrasound will not take away anything else that you should be doing to a patient. It should just be an addition, and it should narrow the diagnosis. What ultrasound does is, you had 10 diagnoses, now you'll be narrowed with about 2 to 3 diagnoses, and you don't have to start treatment in emergency care. You don't have to start treatment for all the 10 diagnoses that you thought about. You can just hit about 1 to 2, and you can narrow and give time to get the diagnosis, okay? We're going to discuss about 3 cases that had FASH findings and were treated with TB. And then eventually I will open up this for discussion. And this is more an insight on how you can use ultrasound. So that 5-year-old gentleman is HIV, low CD4 count of 41. He has symptoms of an infection. Ideally, this patient comes in a limited resource settings. All these cases are from Rwanda, by the way. There are so many other cases from Asia that are out there, but I couldn't get permission to talk about these cases from the others in time. But these cases that we had in Rwanda, and the images are also from Rwanda, with the patient information, of course. So this patient was put on antibiotics because they had fevers, they had signs of infection, they are low BP fluids, This patient comes in, but eventually they are not getting better after some times. In limited resource settings, you have to do a few malaria smear, blood culture, analysis, cryptococcal, nothing is coming up. And chest X-ray. Chest X-ray might be one of the things that you are getting there. Of course, you are looking for source of infection, urinalysis, and everything else. You know, you are doing you are trying to find where the patient, where the source of infection is. Chest X-ray. Talking about chest X-ray, where I worked in, we had almost phased out doing chest X-ray in the department because the first thing is there needed to be a portable chest X-ray. It was half of the time broken. As well, you didn't have accessible to technicians 24/7, so you have to wait. And when they came in, sometimes the quality was not as good, and the patient had to pay for that as well. And what it's going to tell you is there are consolidations. Some of these X-rays might not pick up small consolidations. They might not pick up also small proeffusions that a patient will have, that ultrasound will pick up. So that you have to mind. And what you're trying to answer in emergency settings is a test, especially in limited resource settings, is does this test change management? If the test is not changing management, and it's adding costs, you might think about phasing that away. You want something that is going to be quick, change management, and is affordable and doable in time. So looking at this patient, we had Gene Expert, which was a bedside kind of test done. Of course, it was sputum exam, which was negative as well. This is extrapulmonary TB, and fungal treatment started, but fevers were still persistent, and this patient with the fevers was becoming, BP was dropping. So this is a patient who is hypotensive and ends up being in hospital for 2 weeks and is getting antibiotics, resistance, and everything that you're trying to do. Chest X-ray is negative. What are you going to do? Could it be something else? It can be malignancy, yes, it can be antibiotics. You can argue so many other things, but blood smears and everything has been put in. The patient is not improving. Point of care ultrasound found, as you can see, ideally I would have asked what you guys can see. There's a spine sign there, so that's showing there's proeffusion. You can see a small proeffusion. Probably maybe at that time that might have eventually appeared on the X-ray, but how many X-rays are you going to do on this guy? Are you going to take an X-ray every day? In a high-income country, yeah, you might have done and did CT scans and maybe might have picked that up. But now we're also having hypoechoic lesions. So we have liver abscesses to that patient. I hope that the audience, you can see that slide. So there's proeffusion, there's hypoechoic lesions in the liver, which are abscesses. So you have micro abscesses in the liver. So this patient was started on TB, so a diagnosis of extrapulmonary TB, extending to there's proeffusion, there's also a hypoechoic lesion in the liver, micro abscesses. So started on TB and discharged later. Having said that, there was no way of doing samples on these patients because there was nobody who could do take cultures and take samples from the abscess. He improved in 2 days. And TB also are strong antibiotics. You might argue that, but maybe let's talk about to the next case. Yeah, you might argue, fine, that was another sample of antibiotics that the patient was put on. But let's talk about the next case, maybe we might get more insights. So, because some of these patients, eventually, the ones that we did study on, eventually when we are with developing systems, when we are able to get some of these samples, quite a number of them were becoming positive after that. And that's how we adapted doing FASH, at least in Rwanda, in the emergency department. At that time, TB had gone up, but now TB is going down. I mean, everybody was focused on COVID for the last 2 years. So maybe, who knows? 32-year-old male, fever as well. Same thing, low CD4 count, is quite septic as well. antibiotics, fluids. 1 week down the line, still fever's not improving. And eventually, starting on this, when you scan, you can see paralytic nodes. Let me try to put my pointer. I'm trying to put my pointer. Yep. So that's, hopefully you can see this. That's a spine here. That's aorta. That's IVC here. And you can see a very big node just next to the aorta. I didn't put in a slide for longitudinal. That is in plane of that big node. But as you can see, that's a paralytic node, and this patient was diagnosed also of extrapulmonary TB. The other things that can give you that metastasis in terms of someone having cancer, but and they can give you a similar picture, but not just a localized node that is there. There were some studies done in South Africa and in some hospitals. Patients, sometimes they tried, and in other hospitals in Asia, patients, they tried to open up because this patient might feel a little bit, they might be peritoneal. Mind you that they might have a small ascites, they might be very, very tender. As you can see, there's a little bit of fluid collection here, if you see that. So a little bit probably inflammatory, and this patient had ascites as well. So on exam, these patients might be tender, but they might have signs of kind of peritoneal, but 1 week, 2 weeks down the line, they're still the same. They haven't got worse. They're just quite tender. And some of these patients have tried, there was a report of some places where they tried to open this up, and they had disseminated kind of infection, and most of these patients died. So this is definitely a no-go once you see this. This patient was started on anti-TB, and eventually, when they continued to do gene expert, that's the bedside test, this patient improved and was discharged on TB. So this was a confirmatory test of one of the example where we got extrapulmonary TB. All these 3 patients were followed up after 6 months, and they did very, very well. They went back to their normal life. CD4 count had come up. So that case is a patient with shortness of breath and nice sweats. I mean, this looks like TB, but you don't have a confirmatory test. In terms of the standard of doing TB testing is you get a sputum exam, and once you do analysis a few days, if it's negative, then you cannot start antituberculosis unless they are positive. So this patient, distended neck veins, we are going to Maford ultrasound, pericardial effusion. So that's the pericardial effusion. It's not just a normal pericardial effusion. If you look at, there's like a blanket covering the heart. So that shows you how aggressive this inflammatory fluid is. And this is not just a normal pericardial effusion. If you have uremic pericardial effusion or some other things, metastasis, someone has met, the pericardial effusion tends to be, a hypoechoic and smooth, not this kind of, fibrous tissue surrounding the heart. So this patient was started on TB as well, and improved and later discharged as well. Follow up, the fluid had gone down, but still he had all this pericardial, the fibrous tissue just surrounding the heart. I'm just going to play the pictures of some of the findings. Let me just go out of them. Pointer. Trying to see. How do I? Oh, oops. I was not meant to do that. I'm not very good with technology, as you can see. Trying to come off the pointer. Okay, so that I can play the video. Fine. Okay, that's a pericardial effusion. Remember some patients, the pericardial effusion, this was about 1.5 liters or so. Someone can be working with about 0.5 liters of pericardial effusion and they're fine. Chronic pericardial effusion does not give you, we talk about Beck's triad. The Beck's triad, muffled heart sound, JVD, and hypotension. That is mostly accurate in acute settings. Chronic settings, you might or might not have muffled heart sound, depending on how big the cardiac effusion is. Patient might not be hypotensive. So mind you that this patient will compensate with the tachycardia, so they are not going to be hypotensive. So that was the image. As you can see, that's a nasty pericardial effusion. And that's periffusion as well, massive periffusions that you are going to see eventually with that. That might ring a bell. Let me see if we can get a video of these paraodic nodes. Fine. Concentrate on that one. I play it again. I just point, yep, play it again for the purpose of the audience. And then, fine. And you can see the paraodic node there, how big it is. And these are splenic lesions as well. There was a few cases of patients with splenic lesions. To see them, you can get, the spleen is quite superficial. And if it's not enlarged, you can use a linear probe to get a high resolution with a high frequency probe to get a high resolution. And also you can see splenic nodes there. My splenic microabscesses there, you can see those ones. Quite nasty if you try to drain them. Probably you might need someone very highly trained to drain them, otherwise they might injure easily. Okay. So on the concept of FASH, so this is a point of care test that's going to embrace on the extension of physical exam. There is not a single place that they will say, okay, we're going to exclusively rely on FASH, but this brings an insight, apart from just doing echoes, and everyone is doing echoes, people are doing FAST, you're doing vascular, you're doing so many different. So you have the skills to do an ultrasound, but in the setting of someone who is quite feverish, you have a lot, the patient has fevers, coming to you, they have been treated with different antibiotics. What else can I use ultrasound for, apart from, getting a vein access? What else can I use ultrasound for? Okay, ultrasound is not definitely an alternative to X-rays. That have to be considered in terms of when you're looking at miliary TBs. I'm not sure how you would get all the miliary with just an ultrasound. If you have a chest X-ray, that's fine. But doing an X-ray every other day for a patient, you have to think about the patient pathway, their resources, and what's going to change, and the radiation also that the X-ray comes with. So the FASH sensitivity, there haven't been enough cases to really validate how sensitive and specific ultrasound is. But the more of these things that you have, let's say you have pericardial effusion, you have paraodic nodes, then that makes it more likely. If you had a periffusion alone, then you might have to think about it. Do I just start treatment on periffusion? It has been argued that periffusion that's one-sided is more infectious, and you might consider it. But there's a study we did in Rwanda, which we found that it's about 50% sensitive. It might be a little bit more specific, of course, if someone has HIV and TB. The reason why you're going with HIV and TB, not just TB alone, is because they are more likely to have tuberculosis if they are HIV as well. So that's why it's mostly combined, not just diagnosing of tuberculosis on its own. So there's ongoing studies with FASH to try to validate even more. So sensitivity and specificity gets higher as the patient has more than one of these. And also the patient is more immunocompromised. Of course, with better treatment of HIV that's out there in the world, people are more immunocompetent, in terms of the access to medication is becoming a little bit more easier. And the medication is not, you don't have to take all these tablets now, hundreds of them. Of course, some countries still do, but the treatment and the stigma of HIV is going down. So these patients tend to do better, and you might not just see severe immunosuppressed patients that might be having there. So these are my references, some of my references. Otherwise, thank you for the audience for your time.